Good evening, everyone. Thank you for joining us today. I'm excited to have this opportunity to share with you and also learn from you all. So, before we dive into today's topic, I want to make sure that everyone can hear and see me clearly. And let me know what device are you using to attend to this session from. And I'd like you to type into the chat if you have good audio and video. Type number one plus the device that you're using, maybe a mobile phone or a device or laptop. And type number two if it's not so good and the device that you're using, just to make sure that we can hear you properly. And as we gather your responses, let's go ahead and ready for this session. Okay. All right. So let me just show everyone some housekeeping rules just to help us ensure the session runs smooth. Before we get started, I want to mention that I have no financial or professional connections with any CPAP companies, and the images and content that I'll be sharing today are purely for educational purposes. The objectives for today, at the end of this session, you'll be able to understand the importance of CPAP mask selection. You'll identify the different mask types, evaluate the factors influencing mask selection, implement best practices for mask fitting and troubleshooting, understand the recent clinical evidence supporting the efficacy of nasal masks compared to oronasal masks. Here's a quick look at our session today. We'll be navigating through key topics from an introduction to nasal mask selection, right through the practical insights and a Q&A at the end, depending on how fast and if we have the time. Yeah. So feel free to glance over and I'll guide you us through for each session as we move on. Okay, introduction. So although CPAP therapy is known to be effective and long-term adherence has been consistent and repeated in clinical trials, reported adherences ranges from 40 to 80%. However, 10 to 20% of patients discontinue CPAP therapy after the first night of use. This is due to the discomfort from mask-related side effects. The type of mask has been found to have an influence on tolerance and adherence. And several studies, several studies have shown that oronasal masks have been associated with higher residual apnea-hypopnea indexes and higher pressures than nasal masks when used by the same patient. And this was mentioned by Genta et al. In 2020. And according to that study, the lack of patient acceptance and inadequate adherence remain a major cause for treatment failure. That said, patients' acceptance of PAP therapy depends largely on the selection of proper masks. And studies have shown that when the correct mask type is used, patients experience better sleep efficiency, less breathing disturbances, and thus leading to more effective treatment outcomes. The success of CPAP therapy depends on patients' cooperation and staff expertise. Of course, a well-fitted mask ensures that the pressure is consistently delivered without leaks, which is crucial to prevent these apneic events. So let's briefly talk about comfort and compliance. Comfort is a major determinant whether a patient will adhere to CPAP therapy. Masks that are uncomfortable can cause pressure sores, skin irritation, discomfort that may lead to non-compliance. Nasal masks are often preferred over a full face mask because they cover less of the face, reducing the likelihood of skin irritation and sensation of claustrophobia. Better comfort translates to consistent use of the CPAP, which is essential to managing sleep apnea. Compliance rates are significantly higher in patients who find their mask comfortable. Let's review the mask types, their pros and cons. Nasal masks are often more comfortable, less obtrusive, better for patients who feel claustrophobic with larger mask types. And this was mentioned by Zhu et al. In their study assessing performance of nasal pillows at high pressures versus the nasal mask. Now, it is not suitable for patients who are long-term mouth breathers. The nasal pillows is a minimal contact mask. It reduces claustrophobia, allows for a clear line of sight. Nasal pillows are not so ideal for patients that require high pressure since they direct flow into their nostrils, and this could be uncomfortable for some patients. Some patients may have difficulty controlling the leaks as well. If, as they frequently toss and turn, some patients may experience also higher chances of nosebleed or dryness due to this direct air pressure. So if your patient is not used to breathing through their nose, nasal pillows might not work for them. However, if for example, if a patient is a mouth breather, but they prefer to have the nasal pillows, you can go ahead and use a chin strap for that particular patient. The nasal cradle, almost the same as the nasal mask, minimal contact, reduces claustrophobia, clear line of sight. It can also cause nasal dryness and discomfort. A study found that nasal pillows or the nasal cradle are well tolerated, effective for patients, but requires maybe requiring a CPAP pressures below 14 cm water. The oronasal mask, also known as the full face mask, this is this is different from the total full face mask. The total full face mask. That's not what I'm talking about. So this mask is good for preventing leaks, preventing mouth leaks, because it covers the face and the nose. So it is effective for patients with nasal congestion and blockages. If they have flu-like symptoms too, I had a patient uh, a few weeks ago with that, and he said like it worked for him, and it can cause also claustrophobia and discomfort. It may require higher pressure though. This is because of the larger surface area, and it sometimes in it's a higher chance also for exposure for patients with skin irritation or pressures. This is the total full face mask. It is a good alternative mask. It distributes pressure evenly across the face, reducing pressure points and less skin irritation. It may be bulky for some patients and uncomfortable for some patients. You have probably seen this on the general floors in the ICU, but it's a total the total full face mask that you see for patients in the ICU is different because of the valve that is on the full face mask. This this mask that I'm talking about, the full face mask, it's specifically for sleep patients, for OSA patients. So you've probably seen this, but it's different when you use it in the ICU for respiratory failure. Oral mask, effective for those who do not tolerate or cannot tolerate nasal mask. This can cause dry mouth, dental issues, generally less common in practice, and I believe it's not being used anymore. So I have not seen one here in the UAE, but good to know. Now let's dive into mask fitting. For nasal mask fitting template or a fitting guide, you want to ensure that you align the size the align the sizing guide under the nose so that it flares on both nostrils between the appropriate sizing index. But if you think your patient are between sizes, maybe small or medium, but in between, the recommendation is to go with the larger size as it will be more comfortable for your patient. For using the oronasal mask fitting guide, first align the arrow on the sizing guide to the bridge of the patient's nose, then select the most appropriate size by referring to the area of the guide just below the bottom in the indent of the chin. For under the nose nasal cradle or nasal mask, if you are using a nasal cushion sizing guide included in the mask, hold it horizontally under the nose, then select the cushion size based on where the outer edge of the nostrils and tip of the nose contact the gauge. The cushion opening, which is the triangular opening, can be directed under the nostrils. So this cushion will hug the nose and leak should be at the minimum level. If you are if you are using a gel type pillow sizing gauge, place the pillow cushion on tips of the nostrils, and then choose the cushion size that allows the blue gel bases to sit comfortably under the nose without any gaps. And it's encouraged also to try multiple cushions to find the right size that allows your patient to breathe easily as it has more comfort to fit. Now for nasal pillows, the nasal pillow or nasal cradle frames. So if the frame is rested more at the front or near the forehead, this means it's too small as shown in this example. Maybe it needs a larger size frame. Okay. So if the frame is rested more at the back and off the head or sliding back, that means it's too large. Maybe you need to try a smaller size frame. So you want to ensure also that the straps, make sure that the straps are tightened evenly on both sides. You don't want to go tighter than the other side and not to over tighten the straps. The elbow should stay on top of the patient. So that's why it's called the Teletubby mask. So it should be staying at the top. Shifting gears, the question is, what should we tell our patients when helping them to make a CPAP mask choice? Most of our patients have no idea what to pick. Here are a few points that you can tell them. Any fans of the Matrix? Try not to offer the blue or the red pill, okay? All right, so number one, focus on the long-term benefits of the therapy. You want to make them understand that positive health impact, long-term. Tell them that CPAP can prevent heart disease, stroke, diabetes, be a safer driver, or prevent vehicular accidents. Uh, what how does that feel if you have more time with your kids or stay more focused and productive during the daytime? You want to think about the long term. What is it for your patient? Number two is talk with their sleep partner about any concern that they may have. So some patients and their partners may imagine that the future is going to be a life sentence of wearing a medical device attached to their faces while they're asleep. Now, patients have a fear of being judged or what their bed partner will think. These are the moments where your skills as a sleep expert are needed during your patient encounters, and even for a short period of time. Now, flipping the negative mindset to a positive mindset is encouraged, and you will need to team up with them to encourage your patient. Now, you can tell them that CPAP reduces and eliminates the sound of snoring. While you may not notice too that your bed partner will benefit from a quieter sleep environment. So you can tell them you imagine, remember how it feels like to wake up with a full energy and a clear mind. Number three is get educated on sleep apnea and the benefits of CPAP therapy. Most people don't like what to be told, what they have to do. Some will resist this kind of demand. And again, this is your experience that is needed as a sleep expert. If you could briefly paint a picture for them, the data that show the dangers of OSA and the benefits of using CPAP, they will get a clear understanding and will be able to cooperate with you better on wearing the CPAP mask and eventually tolerate your titration or your split night procedure. Number four is tell your sleep physician if they're having trouble with their mask or equipment. For a returning patient, let's say a retitration night, some patients find it difficult communicating with their docs, especially if you work in a region, on a facility with different cultures or different languages. So explain that the wrong mask can lead to non-compliance, and they should work and collaborate with their sleep technologists and doc to find the best mask for them. Another one is it wouldn't hurt to notify your doc about any concerns that your patient might have missed communicating during their encounter in the clinic, or email your doc in advance if you feel that there's a need for the change for their mask, or if you need to dial a home setting, pressure setting in their devices for your patient in the morning after your titration or from your split night. So we have reviewed the types of masks, advantages and disadvantages, and properly fit them based on the clinical situation discussed. I hope you'll be able to recall those clinical situations from your own personal experience. Next up, we'll talk about how different factors affect mask choice. Patient anatomy and facial structure. Now, this study from Go et al. Found that patients with a larger menton labial inferioris to biocular width ratio, which indicates a proportionally larger chin to lower lip distance relative to mid face width, tended to have better adherence on oronasal mask. And this suggests that certain craniofacial features may make oronasal masks more comfortable or better fitting for patients despite of these masks being associated with higher residual AHI and leaks. However, this study advises that the nasal mask should be the first choice during CPAP initiation. This is due to their superior adherence and efficacy, while craniofacial features like the jaw, the face, proportions might influence mask fit and adherence. They should not be the sole deciding factor. Now, ultimately, the mask choice should be a balanced anatomical considerations with the efficacy of treatment and patient comfort. I like this study because it is the first randomized CPAP interface trial in an Asian population. A good distribution consisting of Chinese, Malay, and Indians on this study. And what they did was on this randomized crossover trial involving Asian patients with OSA, is they compared nasal and oronasal masks in terms of efficacy, comfort, adherence, and each patient tried both type of masks during CPAP titration. Their findings on that trial concluded that nasal masks led to better treatment outcomes with lower residual AHI, and better comfort. Or nasal masks were associated with higher pressure requirements and more complex complaints and their discomfort. I'd like to I'd like to show you, or I'd like to share to you the name of the study if you want to dig in. And if you don't have the copy, I can give it to you too. The name of the study is Choosing the Right Map for Asian Patient with Sleep Apnea, a randomized controlled crossover trial of CPAP interfaces by Go et al. This is back in 2018. Breathing patterns and certain sinonasal disorders or sleep disorders may necessitate specific mask types. For example, patients with high apnea hypopnea indexes may need mask that provides higher pressure settings. Elevated BMI might need a higher pressure settings from a full face mask to ensure consistent seal and a good pressure. Specific disorders, whether a patient primarily breathes through their nose or through their mouth can determine the most suitable mask type for that patient. Habitual mouth breathers who cannot tolerate the nasal mask require an oronasal mask in some cases to prevent that air leaks and ensure the effective therapy for this particular patient population. They may need a higher pressure as well. Sleep recession sometimes and lifestyle choices. For example, we have some patients who wear glasses when using the full face the nasal mask or their nasal pillows. So side sleepers may find that helpful too because side sleepers may turn and twist. So they're more comfortable. It allows them for greater range of movement without disrupting the seal. This is a decisional algorithm for choosing the right mask during your PAP titration in OSA patient. This came from the study of Borel et al. In 2016. And if you want to dig into studies, so the name of the study is Choosing the Right Mask to Optimize CPAP Treatment for Obstructive Sleep Apnea by Jean Christian Borel et al. And for those watching us on their phones, I'm not so sure if you can see this, but let me know again at the end so I can send you this too. With that in mind, let's turn to the three main obstacles. There is a workshop report from the American Thoracic Society, and they found that three main obstacles to overcome and when introducing masks to our patients. And I believe that these are important obstacles for us sleep techs to be aware of. Obstacle number one is dismantling preconceived notions and expectation of what CPAP will and will not accomplish through patient orientation. Although some patients believe that CPAP is the answer to all of their problems, other patients believe that it will not help at all. Obstacle number two is combating claustrophobia. Patients describe experiencing distinct types of claustrophobia. Number one is discomfort from having a physical object on the face. Second is having a confining space to breathe into. So determining which type of claustrophobia the patient is describing will allow the sleep technologist to choose the appropriate mask for the patient. Obstacle number three is the potential that oral leak may influence the overuse of oronasal mask as the initial mask of choice. The DME companies may induce the use of oronasal mask because of additional potential reasons. Number one is higher profit margins of oronasal mask as compared to the nasal mask. Number two is limited mask options and possibility of mask switching. And the third is reduced time for patient adaptation and education. Not so sure if number one and two still happening here in the UAE or other places, but maybe in the past. This report also mentioned to consider a few things when mask fitting. So Instead of asking your patient, do you breathe through your mouth at night? Sleep tech should be focusing more on observing the video evidence because many patients experience oral breathing throughout the night. And as they try to breathe and catch their breath after an apneic event. So it's better to focus on that video evidence. Also, allow time to let your patients buy into that therapy. This increases their confidence and gain commitment early on. And lastly, give a reasonable number of mask options. This is to avoid choice fatigue. So try not to show everything from your can then. Building on that, common issues and solutions. Leak can be caused by poor mask fitting or a leak, patients returning to the lab with their old mask, CPAP circuit, and even sometimes the dirty humidifiers coming over for your sleep study, high pressures or incorrect settings that you might have encountered for retitrations. I would like to give emphasis on mouth leak since this is the most common issue that we all face at night, or maybe for some. This is a 120-second tracing that allows that shows the CPAP device or the C-flow leak and the delivered pressure at the device outlet. This patient was wearing a nasal mask and a chin strap. At the transition to REM stage, a large increase in the leak was noted, and the patient was noted to move, but video evidence show that one corner of the mouth had slightly open. So just be mindful that the increase in leak signals lags behind the obvious change in flow that occurs a few seconds earlier. The trend in the leak is more useful than the absolute number. So if the patient has not moved and leak suddenly increases, this could be a sign that mouth leak is recurring, assuming that the patient is wearing a nasal mask. Sometimes an increase in leak can occur with the onset of REM sleep. Relaxation in the facial musculature can sometimes reduce mass or mouth leak. So REM, remember, stage R is associated with muscle hypotonia. So no need to necessarily intervene to fix unless mouth leak is rousing your patient or preventing that CPAP from maintaining that patent airway. If mouth leak is a problem, you might want to get in and try to get a chin strap for your patient. This is a change in expiratory flow combined with expiratory snoring, suggestive of an expiratory leak. I want you to notice and compare the truncated expiratory flow in EPIC 602 with the normal expiratory flow in EPIC 600. This is due to expiratory mass or mouth leak if the patient is using a nasal mask and this patient was using that nasal mask and a subtle lip fluttering was noted on that video evidence. The expiratory flow is truncated because part of that expiratory flow does not pass into the tubing and it escapes from the system. Therefore, it is not sensed by the device airflow. So inspiration is upwards, as you can see here. All masks have an intentional leak rate built into the design to prevent rebreathing of CO2. This intentionally expected leak rate varies with the pressure level. As the pressure goes up, so that's the intentional leak rate for the mask. The leak rate also varies from mask to mask, so make sure to check the pressure flow curve printed on the manual under technical specifications that the mask uh, says on the manual in the package. So typically, the full face masks have a larger intentional leak rates than the nasal mask or nasal pillows when used under the same pressure. There are three types of annoying leaks. Leaks that are both long enough and large enough to adversely affect your CPAP therapy. That's one. Two is leaks that are not long enough or large enough to adversely affect your CPAP therapy, but which are annoying enough to disturb the quality of your patient's sleep. And third, leaks that are not long enough or large enough to adversely affect your CPAP therapy and which do not disturb your patient's sleep. You only need to work on fixing the first two types of leaks. Small leaks which do not wake them up and lead to obvious restlessness maybe during your titrations, that can be ignored. Titrations can be ignored with that, little ones. Now, in reality, efforts to try to eliminate these small leaks may create problems in terms of patient comfort or patient's ability to get back to sleep or to stay asleep. So the large, long leaks need to be addressed because they affect your CPAP therapy, and ineffective CPAP therapy might not allow your patients to feel at their best. If your leaks are frequent and in the large leak range, maybe you need to spend more time in figuring out what's causing the leak. Make sure that is the correct mask size. Maybe you need to make sure that it's fitted properly from the beginning or before the night starts. Asthma and flare-ups, rain out. So it's a good practice to preheat your humidifier 20 minutes at least to start CPAP titration if you can. Remember that cold air may trigger asthma symptoms and flare-ups for some patients, especially when there's dryness in cold air. Another issue is rainout. Rainout occurs when the temperature in the room is set in a cooler temperature and the humidifier is turned up high. If your patient experiences rainout, just turn the humidifier down a bit and that may help too. Also, if you have a hose cover, the tubing cover, that may help too with the rainout. These patients will still be able to receive the humidification, the humidity, but without the water buildup. Or you can also keep it under the blanket, and the blanket and the body temperature of the patient will help prevent that rainout from occurring. So others might ask, Alden, what about nasal steroid for nasal symptoms or nasal congestion? Well, this table will give us the answers from a blinded randomized control trial by Ryan et al. And what they did on this study is to compare CPAP treatment with CPAP plus humidification and CPAP with steroid therapy with fluticasone. And what they found in this study is that heated humidification and not steroid therapy was able to decrease the incidence of nasal side effects in patients with OSA, initiating nasal CPAP. So the nasal symptoms were more commonly reported in the dry group, which is 70% represented by the black bar, and the fluticasone group, which is represented by the white bar, which is only 50, which is 53%, and the humidifier group, which is 28%, which is the lowest. Let us move on and look at the clinical evidence comparing the nasal mask versus the oral nasal mask. Now, this research found that the nasal and the oral breathing routes have different impacts in OSA treatment. Nasal CPAP generally provides more effective airway support as it keeps the airway open without causing posterior movement of the jaw or the tongue. In contrast, using the oronasal mask or relying on oral breathing can push the tongue or jaw backwards, narrowing that airway and potentially worsening OSA. Additionally, oronasal masks tend to require higher pressures and more prone to leaks, which can further reduce that treatment effectiveness. In this study by Landry, using cine MRI sequences showing retroglossal airway slices from frames for the same participant in same condition, you see the red areas that reflect the semi-automated airway area segmentation, and this visually represents the significant differences between oronasal and nasal masks in terms of pressure requirements, collapsibility, and anatomical changes. The images show that oronasal masks require higher pressures to keep the airway open comparing to the nasal mask. This is because oronasal masks are associated with a higher pharyngeal critical closing pressure values, indicating more of the collapsible airway. Additionally, the cross-sectional areas of the airway, particularly the retropalatal and the retroglossal regions, are larger with nasal masks. And this means that nasal masks are more effective in maintaining that airway patency, reducing the risk of airway collapse during sleep, and enhancing patient comfort and adherence to therapy. In conclusion of this study, the delivered the CPAP delivered on the oronasal mask worsens the airway collapsibility, resulting to an increased CPAP level being required to induce that upper airway obstruction. This is a study by Borel et al. In 2013 involved a prospective observational cohort design, the largest, where 2,311 patients with OSA were followed to evaluate the impact of different CPAP mask interfaces, nasal mask, oronasal mask, and nasal pillow on adherence. Patients who were controlled or who were enrolled, on this uh, French study. I can read French, so I'm gonna say OSFP. If you need this, study, I'm gonna send it to you. I'm not good at in French. It's a bit nasal too when you read it. So the OSF is a database in France which includes anonymized medical records from various healthcare facilities. And this table illustrates the proportion of CPAP-related side effects reported by patients according to the type of mask they use, nasal mask and the oronasal mask and the pillows. Now, the graph highlights that the patients using oronasal mask experience a significantly higher incidence of side effects compared to those using a nasal mask or a nasal pillow. Now, these side effects included dry mouth, choking sensations, psychologically perceived inconvenience. For example, the dry mouth was much reported for more frequently by patients using the oronasal mask with a significant difference compared to the nasal mask, supporting the study's conclusion that oronasal masks are associated with greater discomfort and may contribute to non-adherence to CPAP therapy. Uh, this study suggests that nasal mask should be the first choice for initiating CPAP therapy. This is due to the association with better adherence and fewer side effects. When an oral nasal mask is used, careful monitoring should be recommended and to ensure this patient remains adherent on that mask. So what they did on this study by Roland et al. Is this is a study from conducted in Australia from a sleep disorders unit, and it is a randomized crossover trial involving 48 patients with moderate OSA. And they compare these three types of interfaces: nasal mask, nasal mask with chin strap, and oronasal mask. Each mask was used by the participants in 4 weeks, and various outcomes such as CPAP adherence, mask leak, residual AHI, patient comfort, sleep quality are all recorded. And what they found while CPAP adherence was similar across all mask types, the nasal mask resulted in lower AHI, fewer mask leaks, and higher patient comfort compared to the oronasal mask. And patient reported better sleep quality and greater overall preference over the nasal mask. The nasal mask with chin straps was also effective, but did not show much significance over the nasal mask. So in conclusion, in this study, the investigators concluded that the nasal mask should be the first choice. Again, the first choice for most patients starting CPAP therapy due to its effectiveness in reducing the AHI and providing better comfort. The oronasal mask was associated in higher residual AHI and more side effects, making it less preferable for other patients unless the nasal route or the nasal breathing is not feasible at all. This is from Andrade et al. Maybe some of you have seen this study, a schematic illustration. A is that illustration is where the patient has obstructive sleep apnea showing retropalatal obstruction during the negative pressure generated during inhalation. B, which is in the middle, is nasal CPAP that splints the airway. And C on this illustration is the tongue displays posteriorly and obstructs the upper airway with an oronasal CPAP. This is this interesting study is by Andrade et al. And what they did was this was carried out in Brazil and involved 18 patients with OSA. The research team compared CPAP therapy delivered by a nasal mask versus oronasal mask. And the study incorporated nasoendoscopy to observe the changes in the upper airway during sleep when CPAP was switched to nasal to oronasal routes. Patients were tested for the effectiveness and of the different masks in preventing airway obstruction during CPAP therapy. And what they found was the oronasal mask caused more upper airway obstruction due to the posterior displacement of the tongue and even higher pressures. And these led to worse treatment outcomes, such as higher residual HI compared to the nasal mask. The special mask that they use here, so patients wore a customized oronasal mask with a separate nasal and oral compartment sealed to the skin using a spirit gum. It's a Graftobian gum. It is a brand of professional makeup and sealant used in the movies, or if you're doing cosplays, this is the gum that they're using. And the what they found here is so that the same investigators unaware of the patient's AHI conducting all endoscopic procedures to maintain that objectivity. If you want the name of the study, it's called Impact of Acute Changes in CPAP flow route in sleep apnea treatment by Andrade et al. That's 2016. In the first half of that study, the first half of the CPAP titration study, the patient used nasal mask with the pressure setting of 7 cm water, which is effective in keeping the airway open. The corresponding endoscopic image shows the clear oropharynx with no obstruction. And then in the second half of the study, the patient switched to oronasal mask, and despite of increasing the pressure to 16 cm water, obstructive events still persist. And so the endoscopic image showed that significant posterior displacement of the tongue causing the airway to narrow and contributing to persistent upper airway obstruction. So they concluded that they found that the acute changes of flow route during sleep from nasal to oral and oral routes induce obstructive events in the vast majority of patients with OSA and decrease the oropharyngeal dimensions. So this study raises a warning and illustrates that the oronasal CPAP may compromise OSA treatment effectiveness. So So what? So that's their findings, and that study by Andrade et al. This evidence illustrates the effects of different CPAP routes, nasal, oronasal, and oral. So on the retroglossal airway, the space behind the tongue, so it shows here that the images show the retroglossal area and the difference between the anatomical structures such as the epiglottis and the posterior pharyngeal wall. In the nasal route, the retroglossal area, which is most open, the areas that was measured is at 7.88 millimeters square, allowing effective airflow during therapy. When switching to the oronasal route, the airway narrows significantly with the area reduced to 2.41 millimeters square, indicating a higher risk of obstruction due to the posterior displacement of the tongue. Now, in the oral route, the airway is almost completely closed with an area of zero, showing that most severe obstruction. So the figure demonstrates that the nasal CPAP route is the most effective at maintaining the open airway. While the oronasal mass and the oral route significantly reduce the patency, increasing the risk of obstructive events during the patient's sleep. This table shows four cases are presented demonstrating significant residual upper airway obstruction with CPAP delivered by an oronasal mask, leading to treatment failure, which was corrected by switching to a nasal mask that was set in two of the four cases to a substantially lower CPAP pressure. So in each case, changing to an oronasal mask allowed adequate control of the upper airway obstruction with significant reduction in the average residual HI to acceptable limits on this table. This is a polysomnography summary of case number one, the first line from the previous slide. And this is a 38-year-old male with a diagnostic HI of 50 from the previous slide showing CPAP titration findings from the two mass interfaces on the same night. The summary demonstrated that changing from a full face mask to a nasal mask lead to resolution of the problem. This is one of our patients being titrated at 22 over 16 centimeter water using an oral nasal mask exhibiting obstructive apneas and desaturations and arousals. This is what happened when that patient was switched to oral nasal mask to a nasal mask with the same pressure setting. And this shows that the PSG summary of that patient, of our patient, well, that was switched from oral nasal mask to a nasal mask. Before we wrap up, let's quickly review the takeaways from this session. There are main points that will need to help you select the most effective CPAP mask for your patients during your titration, ensuring the better treatment outcomes and patient adherence. So let's jump over to the important notes one more time. Nasal masks outperform oral nasal masks. Findings were clear. Nasal masks generally perform better across multiple studies. Nasal masks are shown to require lower CPAP pressure, provide better control of upper airway obstruction, and result in lower residual AHI, higher patient comfort and adherence. Patients on nasal masks consistently reported greater comfort, leading to better long-term adherence to CPAP compared to oral nasal masks. Oral nasal masks may compromise efficacy. Oral nasal masks were associated with higher rates of airway obstruction and required significantly more pressure to be effective, making them less effective for many patients. Mask choice should be individualized. While nasal masks are generally the better choice for most patients, mask selection should always consider individual anatomy and patient preferences. Or nasal mask may be appropriate in cases of nasal obstruction or when nasal masks are not tolerated. Thank you so much for your attention today. Now I'd like to open the floor for any questions and thoughts you might have. Just feel free to type in any questions in the chat, or if you'd like to share your experience related to a CPAP selection or a mask fitting, I'd like to hear that too. Your experience can help everyone here, so don't be shy. There are no wrong questions, whether we have covered that or the experience that you had. Let us know. Let's have an open discussion.